people really are whole people. The needs and conditions and services that our Medi-Cal members need, they are not sliced and diced by, is this a physical health condition? Is this a mental health condition? Is this about my transportation? Is this about my food or other social drivers of health? People are literally just trying to cover all of their bases and lead the best lives that they can.
Welcome to The Other 80. I'm Claudia Williams. The most listened to episode of this podcast so far is my conversation with JC Cooper about the first year of California's Medicaid program, CalAIM. And it's no wonder interest in the program is so high. The scope, scale, and timeline for what California is doing is truly breathtaking. So I'm delighted to welcome Dr. Palav Babaria onto the show for another CalAIM check-in, this time from a population health management lens. Dr. Babaria is a primary care clinician who heads up quality and population health management for California's Medicaid program. She joins me to chat about some of the big learnings to date from CalAIM and the soon-to-be-released population health management service. A quick one-on-one on terminology so we can get right into this episode. PATH is a program that provides technical assistance and capacity-building support to community organizations that are new to Medicaid. Community supports refers to the 14 social services offered to Medi-Cal members through CalAIM. ECM stands for Enhanced Care Management, and community reinvestment is the new requirement that Medi-Cal health plans invest 5 to 7.5% of their profits back into communities. So please join me in welcoming Dr. Palav Babaria to The Other 80. It's so wonderful to have you on the show. And just as a way to start, could you share with our audience what's important to know about you? And also just start with your name.
Absolutely, especially because it is often mispronounced, but I am Palav Babaria, and as I think most of the listeners will probably know, I'm DHCS's Chief Quality and Medical Officer and Deputy Director for Quality and Population Health Management, which means that really me, and more importantly, my team, are responsible for improving the quality and equity of care and striving towards population health and wellness for the almost 15 million Medi-Cal members that we cover across the state. I think the most important thing to know about me is I'm a primary care provider. I still practice and I still see Medi-Cal members once a week in a clinic near my house. And what gets me up and out of bed every single day is a vehement passion towards ensuring that the patients I care for have access to the same quality of care that I would want for myself or my family throughout the Medi-Cal program. And I'm also a mom of 2 in my spare time. So,
okay, great. We've spent much of the last season on this podcast really having a profile of whole person care efforts across the country and the wonderful benefit we have in California. I think of it as being able to fast forward to the future because California has been such a leader in this space. So we get to see what's working, what's not. And I would just say kudos to California, kudos to you and your team, both for being incredibly ambitious, but also being very open about how it's going, because I think that everybody's sort of tuning in so they can also reflect what you're learning as they go about their work in their own states. But as a way to orient all of us, I'd love to have you say, what do you think is the core premise of CalAIM? Pull aside all the fluff and get down to the kernel. What is being tested in this ambitious program?
I think there's 2 major themes that I think about, and you'll see them reflected throughout our population health management strategy as well. That one, people really are whole people. The needs and conditions and services that our Medi-Cal members need, they are not sliced and diced by, is this a physical health condition? Is this a mental health condition? Is this about my transportation? Is this about my food or other social drivers of health? People are literally just trying to cover all of their bases and lead the best lives that they can. And yet the way our systems are set up, whether you're thinking about which government entity oversees those benefits, to which managed care plan provides the services, to which providers provide different parts of care, to how they interact with social services sectors or schools, all of those pieces are fragmented. And yet that is not how people lead their lives. And that is not how they experience health and wellness. And so I think CalAIM is turning that premise on its head to say, instead of putting the burden of navigating all this fragmentation and forcing our members to be the glue in a broken system, how can we connect the pieces of the system and really wrap it around the member to achieve that vision of true whole person care with one-stop shopping? Obviously, that is easier said than done when literally every element of healthcare is fragmented and siloed. And so I think the other thread of that is, how do we break down the silos in healthcare? And I hear this often, right? That, this is an unrealistic expectation because I don't control this, or this is an unrealistic expectation because I don't pay for that service. Some other partner over there does. And the reality is when we only focus on that which we control or pay for, or the services we provide, we will never get to that whole person care vision. And so it's really thinking about, how do we integrate, how do we partner, how do we break down those silos, but recognizing that is deeply uncomfortable for most of healthcare.
I love that approach too, because it's true that with the fragmentation, nobody is accountable. And we have to introduce new structures, new expectations to get even halfway there. Two of the most important foundations of this effort are enhanced care management and community supports. And you mentioned the one-stop shop. And I think this concept of having a care manager who's not just there to help you figure out your specialty appointment, but can look broadly across all of your needs and help you navigate to the right spot and help you resolve issues as you come across them, and provide that one stop is really important to the program. I'd love to hear your update on how that's working, what models, different plans, different communities are approaching this differently. What seems to be working the best as we provide this enhanced care management benefit to Medi-Cal enrollees in California?
It's a great question. And, for any entity that is on this journey with us, or other states that are starting to look at this journey in the future, I will say, someone told me when I started at the state, the policy is the easy part. And then actually driving it all the way through implementation, operations, and actually receiving the member in a high impact way, like that's where it's death by 1,000 paper cuts sometimes. And we are experiencing all of those paper cuts right now. But the beauty of being on a quality team is that's what we do. We learn, we grow, we fix, and we make progress. And so for enhanced care management specifically, as you are aware, a lot of our early practice in this space was through our whole person care program in our last 1115 waiver. And through that program, we learned a lot about adults. We learned a lot about complex adults and those that were often in the emergency room or in and out of the hospital or skilled nursing facilities. And so we had a lot of models to build upon there, many of which are really more clinically intense, rooted in primary care, rooted in hospital systems. We have built on those models, but where we are really learning a lot is that's not the same model that works for children and youth. And then within children and youth, we have 9 different subpopulations of focus. And what children with complex medical needs like cystic fibrosis in our California Children's Services program needs is very different than what a child, who's in the foster care system needs, who has a totally different set of priorities. And so what that launch has really challenged us to do, and it's similar to lessons we've learned with our long-term care populations of focus, or our birth equity populations of focus, or now moving into our justice population of focus, which just launched a few months ago, is for ECM to be effective, it is not one size fits all. And where we are most successful is where we are building on deep local expertise and knowledge, whether that is finding that CBO who has worked with foster youth for the last 30 years and then teaching them, here's how you can also be a Medi-Cal provider and get paid for these great services and connect more intentionally to healthcare, or finding those CBOs that have worked with justice involved individuals and reentry services and doing the same. But for the most part, most of those really deeply experienced providers are not healthcare providers. If you've never billed for services before or been a Medi-Cal enrolled provider, that's a huge lift that is much more familiar to people on the healthcare side. So I think the big lesson learned is you won't be successful if you have a one size fits all network, but to really build out the nuanced niche network that you need for each and every type of population of focus takes time and takes energy and takes deep relationships in the community that for some counties and some groups have been easier to form than others.
Are there any trends or threads in which kinds of plans or what kinds of communities that seems easier to create that more tailored approach?
I mean, I think certainly the plans and areas where a lot of those local relationships have existed for a long time have a leg up. So plans that have already been working with their public health departments or already working with their social services departments, they are building on those relationships and expanding from there. We know that also geographic areas where there's a hub for the CBOs have also been scaling more rapidly. If you can imagine a small CBO that has a handful of people, for them to contract with the Medi-Cal managed care plan and bill Medi-Cal, that's a much bigger ask than when you ask a hospital or a clinic to do the same. And so some of our regions have been really successful in identifying who the CBO hub is going to be that kind of takes on those functions and then brings a lot of the smaller and medium-sized community-based organizations along. Unfortunately, not every part of our state has a CBO hub, but that is definitely something we are actively supporting through our Cited and PATH program as well. And then, I will call out that I think just the challenges in the rural parts of our state are unique and distinct and is still something we are working through.
And moving on to the community supports, which is the term used in CalAIM and Medi-Cal for what we think of as social care services. So this might be housing navigation, medically tailored meals, respite services, asthma remediation, those kinds of things. So there are 14 of these built into CalAIM. And I think there's a lot of folks interested in which things are getting the most use. Where are we really seeing a large uptake in those kinds of services? And conversely, are there types of community supports that really haven't been used very much? And what do you make of all of that?
So I'm going to put in a plug for those of you who love data. If you Google DHCS CalAIM dashboard, you will get to our CalAIM dashboard, which has lots of numbers and facts and figures on every initiative, including ECM and community supports. And we are now updating that information pretty regularly every quarter with the latest data. And so our latest report, which just launched a few months ago, and our next update should be coming towards the middle of the summer, show that our housing trio is really popular for obvious reasons. The degree of members experiencing homelessness in our state is a major issue, and having these tools and resources to support those members has been really well embraced across the state. Our medically tailored meals program is also really popular and has been embraced, pretty widely across the state. And then there are others that I think largely because of the infrastructure and specialty services that are needed have been slower. So, you can imagine sobering centers. It is harder to just pop up and stand up a sobering center. It's sort of different than having a meals service. Similarly, asthma remediation, lots of potential, but more complicated to make sure that you have the right expertise and can get into people's homes and provide that service.
You mentioned community hubs and where those are available, really relying on those as kind of the aggregators of community services. And this points to something that's a really interesting difference between CalAIM and New York's most recent waiver that was just approved, where in CalAIM, a lot of the responsibility for contracting with community organizations, bill paying to them, and kind of putting together the system of care ultimately rests with the plan. Whereas in New York, the model they're adopting is to actually contract with regional hubs, regional networks, some of which exist, some of which don't yet, which will then in turn be there for all of the plans in a region. And I'm curious, as you look at your experience over the last 2 years, one is just some insight about why was this path chosen? Why was the decision made to rely more on plans? And what are you observing now about the pluses and minuses of that pathway versus what New York is doing?
That's a great question. At some point, I'll have to educate myself more with what New York is doing to be able to provide a more nuanced answer. But As folks probably know, as of January 1, 2024, we anticipate that about 99% of the entire Medi-Cal population will be in a Medi-Cal managed care plan of some sort. That is the reality that we live in now, where almost everyone is in a managed care plan. And I think if we go back to that initial desire to reduce fragmentation, to have a cohesive approach to an individual's benefits and their experience in our program, siloing out ECM or community supports into a fee-for-service model or some other model really takes us away from that goal of this shouldn't just be a side stream that's tackling your social drivers of health, right? This has to be closely integrated with your physical health needs, your non-specialty mental health needs. And that is what we are achieving with our plan partners. And I will say across the state, we're still building, we're still getting our sea legs under us of how do you just do the mechanics, but where some of the plans are headed, which is what I'm most excited about for the future, is how do we not treat ECM or community supports as a siloed benefit? How do we actually take all of these as tools in our toolkit to, again, build that vision of wrapping around a member? People who are residing in a long-term care facility for a long time and want to get back into the community and not be institutionalized, they are eligible for ECM. And there's also a whole suite of community support services like personal homemaker services, housing supports, et cetera, that can make that transition to the community or keeping someone in the community much more successful.
I hate to even ask this because of how incredibly hard everyone's working already. I know the waiver goes till 2026, which means you're already thinking about and starting to work on what do things look like when you have to start putting that together. I know you don't know the exact contours of what that looks like, but what are some of the things you're starting to think about or even assumptions we can make about what the shape of that might look like as you move into 2026?
Well, I'm going to put in a plug that, as you are aware, we have a new state Medicaid director, Tyler Sadwitz. He will be leading us through our next waiver design process. A lot of the themes that we started with, we're not done that journey yet. How do we integrate, not just within healthcare with dimensions of behavioral health and physical health, where we still have significant integration that we've started under CalAIM, but certainly is not going to be complete by 2026, but also this broader journey. We have numerous efforts, both under our population health management program and other policies like our population needs assessment and community reinvestment that are really bridging those divides between healthcare, public health, the social services sector, and at the end of the day, our communities who are the heart and soul of all of our health equity efforts and our current health equity listening tour that we are doing. And there's still so much more integration work to be done in that space that you see reflected in CalAIM, you see reflected in our BH Connect waiver, but I don't think anyone thinks that journey is going to be done in 2 years.
I'm so glad that you mentioned population health management, and that's one of the big chunks of work that you lead along with quality improvement, which are important tenets of all of CalAIM and Medi-Cal in general. And for very unfortunate reasons, I feel like that term, people have become a little jaded about it. And I think it's because if you go to HIMSS, if you go to any of these conferences, everyone is talking about it, but few people are actually doing it. So I'd love to hear about what really sets apart the perspective and work that you're leading under Medi-Cal and for CalAIM around population health management. What's making that real for people, not like the shiny letters on the wall that we see at some of these conferences?
I think a few things, and I agree with you. Sometimes population health just means how are you chasing the HEDIS measure and
Exactly.
achieving blood pressure control, right? And that is not, in our view, population health. That is achieving blood pressure control for a small subset of the population who happens to be continuously enrolled in your plan for 11 months. And when you read our population health strategy, yes, achieving chronic disease management goals is in there. Yes, achieving, immunization rates and cancer screenings for our individuals is in there. But the policy goes much broader than that and has started to raise questions about what are we doing to prevent chronic diseases? What are we doing to prevent people from actually getting diabetes or high blood pressure in the first place? How do we partner with public health to, again, move those interventions upstream? Because we truly do know, an ounce of prevention is worth probably more than a pound of cure these days, given healthcare costs. And I think that is really what is novel, is really that upstream approach, and really thinking about, not population health with a lowercase p, but as my public health friends teach me, population health with an uppercase P, that is really thinking about, how do the green spaces in our communities inform health and wellness? How can we work on public health campaigns that really change individuals' behavior and get them access to the services and systems they need? And so, really thinking about underutilization, who's not showing up at our front door. We know so much of that drives a lot of the racial and ethnic disparities that we see. How do we think about re-engaging primary care as the front door of our delivery system? And so throughout our strategy, those are common themes about really having that continuity with the trusted relationship and going from there.
And I'm so glad you mentioned public health and the new requirement, which is requiring the plans to work with the county health departments to do community health assessment. So now you're bringing, I think, two of the most significant actors together who in turn will work with the whole ecosystem to identify the most pressing community health needs and develop solutions that might knit across both of their jurisdictions to fix those. So how did that idea first kind of gain hold? And tell us a little bit about what you hope comes out of that new requirement.
This is, I'm not going to lie, one of my favorite policies, because I was part of the journey from its inception to its current state, and we're not done. We still need to implement and really help those relationships develop. But I think it goes back to one of our problems in healthcare is we get tunnel vision around what we control and what is right in front of us. And we know that, plans were doing their own community health assessments, often through a managed care and very healthcare lens. Hospitals do their own health assessments to inform their hospital community benefit. Public health does their own assessment that is often more upstream. And all of those efforts are overlapping, but often siloed, resulting in siloed interventions that, can be duplicative or frankly non-effective because they're not leveraging each other's resources or perspectives. And so we really wanted to change that paradigm to say, if you're working in a local community and all of you are committed to health and wellness, which they are, how can you leverage each other's expertise to get there? And when you read our policy guide, that's really what it's based on. Our managed care plans have deep expertise in a number of domains. Many, if not all of them, have really robust data analytics and information about what are we seeing, what's happening to our members. Our public health colleagues are really able to take that information and walk it back 10 steps. Hey, if we're seeing a lot of heart failure, what can we do that is beyond just giving people heart failure medications to actually prevent that, so that we are globally reducing the rates of heart failure in our communities and setting those families up for success. And in areas where those partnerships are already occurring, we are seeing a different way of thinking that is really rooted in the community, putting their interests first, and then coming up with the best comprehensive solution that all of those smart minds can come up with.
So let's talk a little bit about the population health management service. So this was a new idea that resulted in an announcement in January of 2023 to develop a common platform and set of data infrastructure that will cut across all plans. Wondering what the status of that is. It's a very ambitious project. Any updates on the timing or the scope of what will be released?
All great questions. So this project is still happening. It is, as you said, I think has the potential to really be transformational and knit together the data infrastructure that we need to really achieve the objectives that are laid out in our policy guide. And so we are building it and testing it first. So DHCS will be the first guinea pigs, but have already started engaging our managed care plan partners, our tribal partners, and others to start to figure out those subsequent releases for those key partner groups. So we anticipate all of that happening sort of over the course of 2024 and 2025 in a phased fashion. I think a more detailed timeline should be released publicly soon. The core elements of the functionality I think are really important to lift up is that, one, for population health management, right? We know we don't have infinite resources. We can't do outreach to every single person with the same degree of intensity, and really leveraging data to predict who's doing okay and will self-navigate, and who's really struggling and has a lot of needs where they need that extra touch or need the extra care management program or an extra set of services, is a question that is hard for the state to answer today. And many managed care plans use proprietary risk stratification, segmentation, and tiering algorithms today to do that process of saying who's high risk, who's medium risk, who's low risk, who needs different types of services. And we know many of those commercially available algorithms do not protect against racial and ethnic bias. And so some of them are worsening some of our health disparities and leaving out groups who need services. And so one of our commitments as a state was we want to stop perpetuating racial and ethnic disparities. We want to solve them, but we definitely shouldn't perpetuate them. And we need a transparent algorithmic process that we hold all the plans to so that we know apples to apples what is happening across our state, and how do we make sure that the individuals who have the highest risk levels are getting all of the services that they can in the Medi-Cal program. The other thing I'm really excited about, as we talk about with CalAIM, so much of CalAIM rests on getting out of our healthcare silo. The Justice Initiative, huge promise, but what if we don't know that someone's been incarcerated? How do we get them the services that they're supposed to get through the Justice Initiative? Similarly, thinking about social drivers of health. In current state, most healthcare providers and primary care providers, they don't know if someone's enrolled in CalFresh or WIC or what other benefits they might be entitled to that they're not receiving. And locally, there have been great data sharing pilots, but it's hard to scale that across the state. Is every hospital going to try to get every WIC, enrollee information locally with the right consent? And so we are really trying to use the PHM service to collect as much state level data as we can and make it, obviously in a HIPAA protected, privacy and consent managed way available to people who are caring for Medi-Cal members so that they really have the whole picture of what is happening to that member or patient and what they need and can address those gaps.
And I just want to make 2 pointers that relate to previous guests we've had. So we had Ziad Obermeyer on to talk about algorithmic bias and AI and how to guard against those things. So kudos to you guys for really focusing on that. And then just had Maya Peterson on, who I didn't realize was helping lead some of that scientific work around coming up with the best way to use the data in a equity forward and accurate manner. So super excited that 2 of my colleagues at Berkeley School of Public Health are laying the groundwork for some of that work that you're doing, one very directly and one a little bit less directly. I know one of the issues you and I had met on back in 2022 was what are the near-term opportunities to bring in clinical data, not just claims data, into the PHM, understanding that's a tall order and that the clinical data itself is fragmented sometimes. What might we expect out of this first release in terms of the kinds of data that will be there in this first phase and what things will be coming later on?
Great question. And I always tell people, the PHM service is a population health management and analytics tool. It is not a health information exchange. And so, it can use health information exchanges. It itself is not a health information exchange. And so we are starting with the data we have, which, as mentioned at DHCS, is largely claims and encounters, which is still very helpful. But also at the same time, that data reflects something that happened to a member sometimes a year ago. And so our sister parallel effort run by our Health and Human Services Agency friends, the Data Exchange Framework, I think is really critical because it is the framework that will allow the real-time health information connectivity across the state. And when there is enough of that out there, we hope to leverage that information in the PHM service to make the sort of insights and analytics we have much more timely and actionable. But we anticipate that being a slightly future phase once the data exchange framework also makes its own progress.
I want to close out with some questions that take us to broader regional healthcare transformation. And you've touched on this with the requirement that plans work with their local counties, think beyond the accountability that they formally have to really think about how to unleash change at the local level. But first, I want to think and talk a little bit about Medicaid as a force of change in this country. I had Alan Weil on the show some time ago, and he said something that really put in words one of the reasons I get so excited about Medicaid. He said, Medicaid is one of the very few tools we have to actually create delivery systems. The most creative states have figured out how to develop continuums of care to meet people where they are and build the workforce and payment models to support them. And he was actually distinguishing it from Medicare, where you have the ability to create change and innovation, but really this very forward-leaning power of Medicaid to tackle new areas. And years ago, it was around home and community-based care. How do we create a new system of care for people to help them stay in their homes, stay in their communities, and avoid institutionalization? But I think your work and New York's work, North Carolina's work, is really laying out a similarly ambitious and important set of initiatives around equity, around social care and medical care and whole person approaches. I'm super excited about it. At the same time, it's putting a lot of weight on Medicaid, which is itself only one program. What are the limits of Medicaid in taking on that responsibility? That's the first question. And the second would be, what kind of helping hand would you want from other programs and organizations around this transformation effort?
I'll start backwards. I was on a panel recently where someone was asking, is healthcare the best place to solve all the social drivers of health that we see? And a lot is written about this, right? Are we over medicalizing social services? Is it more expensive? Are these the right agents to do it? And, I often think that what we are seeing is what the needs are. And I think why Medicaid has become such a central player is because it is an entity that has levers like the 1115 waivers and demonstrations to do something about those needs. And so having this philosophical conversation of, could it be done better elsewhere? Should it be done elsewhere? There aren't those levers elsewhere for the most part, in our society and in our nation. And so it's hard, especially when most of us who work at Medicaid programs, we really care about the populations we serve. The populations we serve are disproportionately saddled with racism, sexism, a lot of the isms of society, and experience that in their healthcare day in and day out, to not want to do something about it. And laws like EMTALA mean that our EDs and elsewhere in the healthcare system, that is where people show up. And that is where a lot of non-healthcare related needs manifest. And I think that is a large part of why, in general, healthcare has been trying to tackle these issues, and why Medicaid, specifically using the levers it has ventured into this arena. I won't comment on should it be that way, but it is that way because it is one of the most expedient ways available to all of us across the country to make a difference and address real dire needs that patients experience day in and day out. I do think, though, it takes a village. And I think one of the most exciting parts about CalAIM has been to see the different types of expertise that people bring to the table. And, the social services organizations that are now participating in CalAIM, whether it's as ECM or community supports providers, bring a completely different but highly valuable skill set to Medi-Cal members than, what primary care providers bring or what a nursing care manager brings to that member. And to me, that is how we get to whole person care, is with everyone really bringing their unique skill sets to bear in a coordinated, integrated fashion. And so for anyone listening to this podcast who's in California, if you are not a part of the CalAIM journey, we encourage you to check it out. And there's so much amazing, wonderful work happening locally.
One of the recent guests on the show was Tony Eiton, who is the Senior VP of Programs at the California Endowment. And they had engaged in a multi-year $2 billion effort to address and improve community health across California. And the conclusions of that work were surprisingly simple and profound, but also challenging to implement, which is to improve the democracy, voice, and ability of local communities to ask for and get what they want. So much of our current equity situation is based on bad allocation of resources, not around need, but around who had the squeakiest wheel and the loudest voice, right? And so this idea of building activism at the community level, helping people learn the skills of voicing their needs, being represented by people that understand, have lived experience, and all of those things. If you think about that core role of representation, democracy building, voice building at the local and regional level, what is the role you think of this program and Medi-Cal in supporting that?
So not everyone may know this, but CalAIM was generated from a statewide listening tour. Our previous state Medicaid director went around the state and literally asked communities, rooms full of plans, members, providers, what do you need from Medi-Cal that it isn't working today? And literally, like the smorgasbord of recommendations is what turned into CalAIM. And so I think that premise of listening to the community and responding to the community's needs is in the core DNA of this program. I think through our comprehensive quality strategy and other efforts, DHCS is now taking that to the next level. So we launched last year a Medi-Cal Advisory Council, where we have a group of Medi-Cal members that meets directly with our director and executive team to provide feedback, weigh in on policy decisions. As a part of our new 2024 Medi-Cal managed care contracts, every single managed care plan is also obligated to have an advisory committee that includes members to really, again, listen to the community, understand the needs, respond to them. We already talked about the population needs assessment and community health assessment, which is also reinforcing that same principle. And our Chief Health Equity Officer, Dr. Riley, also recently wrapped up the first part of our health equity listening tour across the state, where she and members of our team literally went and met with communities and Medi-Cal members who are disproportionately impacted by health disparities to just listen what needs to change in our program. And the next phase of that work will be turning it into our health equity strategic plan. And we also have a birthing care pathway initiative that will be releasing its public report on how we are going to transform maternity care in California. And a third of sort of our stakeholdering is with Medi-Cal members, both longitudinally and in focus groups, to inform and drive that work. And so we are huge believers in that principle and are trying to weave it in at the state, plan, and local level to the best of our ability. And I will say, as a primary care provider myself, can't say medical school did a great job teaching me this, but in all my years of clinical practice, my patients know what they need and want. My job is to help support them in getting those needs, but there is nothing that they don't know about their own health and what their priorities need to be, to get to the next step in their lives. And it took me a while to learn how to listen and extract that information. But I think if we can do that at scale, we will get to, truly having health and wellness in our state.
I love that story. I've never heard that story before about it coming out of a listening tour. That's fabulous. I'll close with a question I've been asking all of my guests. I just recently took on a new role as the Chief Social Impact Officer at Berkeley School of Public Health. It's a very new role for me. I've never worked in academia or really, honestly, in this manner focused on explicitly on social impact. And the question I have is your invitation of, if you're not already involved in CalAIM, come be part of it. How might you want to see our school, our students, our faculty, even our convening ability, our ability to bring people together in different ways? How would you want us to partner around the goals that you're laying out?
I will say, as a recovering academic myself from way back in my career, what strikes me in California is we have such deep talent, especially in our public UC system scattered across the state. And while there are touch points, with healthcare locally and with government entities, there are so many more bridges to be built there. And I think really thinking about how do we leverage that intellectual capital and those perspectives, whether that is in partnership directly with DHCS in a more intentional way, whether it's at the student level or the faculty level, as well as what are those skills and resources that can really help our plans and our providers really have the data and analytics and insights that they need to continuously improve their programs and make progress. I think there's a lot of untapped potential there.
We'll talk more. Listen, thank you so much for your time. It was fun going back and looking at the timeline. You launched CalAIM in January of 2022. I interviewed JC Cooper. She was one of my first interviews on this podcast. So it's just such a pleasure to come back and hear about all of the progress and the deep thinking you are all undergoing to make this once in a lifetime opportunity make the biggest possible impact. So thank you so much for that.
Thank you. We're not there yet, but I'm confident we will get there one day.
In our conversation, Palav describes CalAIM's approach by using the standard quality improvement rubric: make a change, observe, and iterate. And I really love how that framework is moving California and other Medicaid programs closer and closer to the foundations of health. And so here are the big questions that leads us to. How can Medicaid health plans work with the whole local ecosystem on community health improvement? So not just providers, but also public health, schools, CBOs, sheriffs, and mayors. And what are the opportunities to focus on true population health prevention, food, housing systems, as well as violence prevention and economic justice? This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Palav Babaria and her work on CalAIM. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.